Good morning, everyone. It's an honor and privilege to introduce Dr. Elliot Kozin. He's currently a neurotologist at Mass Eye and Ear. He did his medical school training at University of Pennsylvania, and then internship, residency, and fellowship all at Mass Eye and Ear. His clinical interests include surgical management of chronic ear disease, conductive hearing loss, cochlear implantation, and tumors of the lateral skull base. There's a particular interest in traumatic auditory injury, and today he's giving us a talk on traumatic auditory injury, a new take on an old diagnosis. So take it away, Dr. Kozin, and thank you for presenting.
Well, thank you so much for having me this morning. It's a real honor to be able to present to your group and as part of this education series. As I was saying before, I've watched many of the videos along the way, and I'm really very honored to be able to contribute, my small lecture to your much larger series. So today I'm going to be speaking a little bit about traumatic auditory injury and my perspective and sort of research on this topic. So I don't have any relevant financial disclosures as it relates to this. So just to take a step back, I think most otologists, those that are listening to this talk, when they think about head injuries, they generally think about things like this: temporal bone fractures. These are things that were consulted on as trainees, residents, fellows, and then later see in the clinic as faculty members. These are patients that I saw along the way at Massachusetts General Hospital, an unfortunate patient that had a gunshot wound through the orbit, middle fossa, and temporal bone, including mastoid. And then the more run-of-the-mill temporal bone fractures as it relates to trauma, such as motor vehicle accidents. But there were a couple of cases that I saw along the way, in particular during my training, that really made me think a little bit differently and think about what might be going on with head injury. So I'll very quickly present these two cases. So the first is J.A., a 20-year-old female. She had a concussion from soccer. There was no loss of consciousness. She ended up going to the emergency room where there was normal exam and imaging. CT scan was normal, but she developed pretty significant right-sided hyperacusis, subjective hearing loss, and associated tinnitus. Ended up getting an audiogram, and despite all of these pretty severe symptoms, had normal audiometry. This stands in contrast to this 28-year-old male who had a right head strike from a motorcycle accident. There is similar to the prior case, there was no loss of consciousness, there was normal exam and imaging. When he went to the emergency room, again, imaging like CT was negative. And similar to the prior case, he developed right-sided hearing loss and tinnitus. The major difference was in this case, he basically had no hearing perception on the right side. So how do we make sense of these two very different audiograms, yet very similar patients? So this is really the central question of the talk that I'm going to give today, and really the thrust of what I'm doing research currently, which is how does head trauma cause auditory changes? I think if we look at the classic textbooks in neurotology, and your group's textbook is front and center here, is we really see much of the same thing, which is cases like this, really traumatic and temporal bone fractures, where they speak a lot about how to repair things surgically. Cerebral spinal fluid leaks, when do you observe, when do you place antibiotics, when do you take them to the operating room? Things like facial nerve injuries, again, when do you observe, how do you decompress one, when would you decide to operate? And lastly, things like hearing loss. But the hearing loss that's commonly described in these textbooks are more for conductive hearing loss, what might occur after temporal bone fracture or some sort of vesicular chain disruption, and when might you take them to the operating room. But maybe there's another perspective that we're somewhat missing as otologists or neurotologists, and really otolaryngologists in general. And I think to think about this, we really need to look at the literature from a slightly different perspective. And the main way to look at it isn't so much our somewhat narrow view of temporal bone fractures, but really traumatic brain injury, which really is a huge field and huge area of research. So for those that are less familiar as otolaryngologists, we really don't have that much training in TBI. It's millions of ER visits, hundreds of thousands of hospitalizations, and unfortunately, tens of thousands of deaths. The economic cost of traumatic brain injury is huge, many billions of dollars per year. And if you look at the literature, albeit a small literature, the prevalence of hearing loss in this specific patient cohort is nearly 70%. And so I think one of the issues as we're addressing this clinical problem is this puzzle is sort of in different pieces, and it's in different pieces based on the specialties. You have emergency medicine providers involved, neurologists, obviously ourselves, otologists, neurotologists. We have our audiology colleagues. We have our audiology neuroscience PhD colleagues, our PM&R colleagues, and finally PT and OT. And we all describe this phenomenon somewhat differently. And it's really been my thrust over the last few years to try to put these pieces together in a way that maybe makes sense based on sort of the more global literature that's out there. So over the next 45 minutes or so, I'm going to speak a little bit about how I'm trying to put these pieces together, a little bit of the historic perspective, epidemiology, speak a little bit about human physiology. The major thrust of the talk today is going to be postmortem human otopathology studies, speak briefly about animal studies, and then finally end with therapeutics and sort of the unknowns in the field. So first, especially speaking to the house group, I don't think you can give a talk without speaking a little bit about history. This goes, predates the house group back in, Western Europe and Germany and Austria, where you had some of the forefathers of otology as well as otopathology, Pulitzer, Passau, and Swartz, who were both the original otopathologists as well as otologists. And interestingly, if you go back over 100 years ago, sometimes 120 years ago, they all described this phenomenon. This you could see is in German because that was really the language of medicine at the day. And we did sort of a systematic review of what existed, or really what exists in the literature on this topic. And you really have to go back 100 years. We actually had a German-speaking student who was able to help us translate a lot of this, but you don't need to speak German to understand some of these words. Labyrinthine trauma, labyrinthine lesion, and a lot of the original otologists and otopathologists described this clinical phenomenon. They not only described it clinically, but they also studied it mechanistically. And a lot of the original animal physiologists, Stenger, Whitmack, Brunner, and Dr. Shupnik of Mass Eye Near, who was really the last person to study this in any great degree, developed animal models. And you could see here rat models, rabbit models, guinea pig, and even cat models. And what we found was really Dr. Shupnik's study back almost 70 years ago was really the definitive study to the day. There have been a couple of studies that have occurred after this, but this was the most significant study. And in doing this paper, I actually went to some of the technicians who worked with Dr. Shupnik, and they were able to uncover some of his slides that some were published and some weren't. So I say this is courtesy of Dr. Shupnik because this really hasn't been seen since 1949. But what you can see here is a feline or cat model of an animal that underwent an injury to the side of the head. Before the injury, they were actually trained to respond to pure tone audiograms. And what you can see in this low power magnification cross-section of a feline inner ear, you can clearly see the turns of the cochlea, you can see the vestibule, cochlear nerve, but you also can see under lower power magnification, heme, the scala vestibulae. And you could also see this beautiful depiction here, not depiction, but actually photomicrograph of spiral ganglion neurons. This is another cat that had a head injury, and you could also see heme. And in this case, there was a loss or missing of spiral ganglion cells. You could see under a higher power magnification of the organ of Corti, absence of inner hair cells, outer hair cells, and really degeneration overall. And this was based on the behavioral responses that Dr. Shupnik did with his cats. And what you can see here with these cytocochleograms, that you see a response that's similar to what one might expect after noise exposure. And I'll focus everyone's attention to D here, which you could see there. He studied the cats over time, and you could see there was a severe loss of hearing really at the higher frequencies at day 1, and then 3 weeks after injury, there's a resumption of some degree of functional hearing. And really, that's where we sort of understand it today. Dr. Shupnik, in his papers, was able to describe this. to a certain degree, but really did not come up with anything definitive. Some had no cochlear changes, others had changes just to specific parts of the cochlea, and others had widespread changes. And what he concluded, and this is taken directly from his paper in 1951, and I'll read it, is it appears that a blow to the head may cause a pressure wave in the skull, which is transmitted through bone to cochlea, just as a pressure wave is carried by a conducting mechanism. So in other words, he likened this to an acoustic overexposure. And 70 years later, this is really what we know of this phenomenon in terms of physiology, at least in a behavioral level. So when we look in the textbooks, as I described before, these are the things that people describe: an acute hemorrhage, an excessive fluid wave, stretching or tearing of the cochlear nerve, trauma to the membranous labyrinth, development of cochlear or endolymphatic hydrops, and then central auditory pathway changes. And so when you see a patient that has, as I described before, who has essentially a dead ear or severe to profound hearing loss without any clear imaging changes, we generally describe this as a labyrinthine or inner ear concussion. And this has become somewhat of a wastebasket term for all these mechanisms that we really don't know which is the case, or it could be many of them. So that's sort of how I began studying this, is just taking a look back to say, well, what has existed? What do we know about this topic to date? So I wanted to move forwards a little bit and say, well, how much of an issue is this really? So to do this, we did a systematic review. This is going back a couple of years, and I wanted to look at traumatic brain injury, or TBI, literature, and specifically look at studies where they measured pure tone behavioral audiometry, but also had CT scans to rule out temporal bone fractures. And so what we found in this fairly simple systematic review is that when we looked at 13 studies in patients who had pure tone behavioral audiometry in the absence of temporal bone fractures, up to 60% of patients experienced hearing loss in the absence of a temporal bone fracture. So clearly, we don't know if this is conductive or sensorineural, but clearly there's something going on here that maybe warrants further investigation. Took it one step forwards and said, well, maybe we need to study this locally. That's sort of looking at more of a systemic approach that looks at existing literature, but what about at our own institution? So we looked at a dedicated rehab hospital. It's effectively across the street from Mass Eye and Ear, and said, can I study your patients? And so we looked at two cohorts, those with mild TBI and those with controls. And I think the controls is really what made this study novel, because a lot of the prior studies didn't use age-matched controls. A lot of people developed tinnitus, hyperacusis, hearing loss later in life, and we really want to make sure that this is due to traumatic brain injury, not just due to aging or noise exposure. So we really just looked at adults. We excluded patients who had other otologic issues, or those that might have hearing loss due to, say, occupational or military work. And so we looked not just at hearing loss and tinnitus, but other symptoms as well. A lot of studies have really only looked at things like hearing loss and tinnitus, and a lot of patients won't tell you about other symptoms unless you ask them. But things like hyperacusis, autophony, and oral fullness are real symptoms. Patients are quite bothered by them, but they often will not tell you unless you ask them specifically. And we wanted to do this in a pretty robust way, where we not just ask them a sort of a binary way, do you or do you not have these symptoms, but how much is it affecting your life? So to do this, we used patient-reported outcome measures. And so what you could see here, this was sort of the major finding of the study. And on the y-axis, you have the percentage of patients, and the x-axis, you have the symptoms, is what symptoms were they having compared to age-matched controls. And clearly, the patients following traumatic brain injury, mild TBI in particular, were having many greater symptoms than their colleagues. We also wanted to know, was this bothersome in their daily life? And what you can see here, based on the patient-reported outcome measures, this isn't just a mild handicap, that many of the patients said that this was a more severe or moderate handicap based on their life. So clearly, based on this study, this is maybe a problem that we should be looking into more, because it's clearly affecting their daily lives. I wanted to ask the next question, well, what about patients with TBI and normal pure tone audiometry? So we didn't look at the pure tones for those patients, that many of them could have had hearing loss associated with the injury or other reasons, but what about those with just normal audiograms? And so what we found in this study, even in patients who had normal audiograms, they were still symptomatic. In that binary assessment, they had hearing loss, they had tinnitus compared to their cohorts, and it also bothered them in terms of patient-reported outcome measures. But this is clearly sort of a biased cohort. These are individuals who are going to a TBI clinic weeks or potentially even years after injury. Many of the patients who had a TBI might have recovered completely. And so clearly we're looking at a very small cohort here. So what we wanted to do is look maybe more epidemiologically to say, well, you could capture patients more in a cross-sectional area who aren't necessarily self-selecting out for symptoms. So to do this, I turned to a colleague, Dr. Neil Bhattacharya, across town at the Brigham and Women's Hospital and said, can we do an epidemiologic study or use current epidemiologic data to assess if maybe head injury is associated with hearing complaints? So to do this, we used the National Survey of Children's Health survey for 2017 and 2018. And importantly, it had these two important questions. First, have you ever essentially had a brain injury, concussion, or head injury, either before or currently? And secondly, there's a hearing question on this survey. Does your child have deafness or problems with hearing? So with these two questions, we can begin to think about associations between head injury and hearing issues. And so using this epidemiologic study, you can essentially assess a weighted average of 73 million children. And notably, 3.1% of these children or their caregivers reported a history or concurrent traumatic brain injury. And the major takeaway from this study was that children who reported a history of traumatic brain injury, their caregivers were 2.67 times more likely to report some type of hearing concern compared to their age-matched cohort without a TBI. So clearly, hearing concerns are associated with the TBI. And importantly, what we also found was that hearing concerns were associated with worse injuries. So depending on the severity of TBI, the hearing concerns were worse. So that was interesting. We said, okay, maybe there's an association here, but what about simple things like sports? What if you look at sports where there might be head injuries associated with it? So we looked at another survey, this National Health and Nutritional Examination Survey for 2015 and 2016. And this looked at kids who were aged 5 to 15. And we were able to look at whether they played sports or had a history of playing sports and what their parent derived sort of hearing quality was. And what you could see here on this plot, if you look at sports like swimming, baseball, soccer, basketball, where there really isn't a great association with head injuries, there really wasn't a significant change in their hearing quality. But if you look at a sport like football, where clearly there are more head injuries, you do see that children practicing football were 1.56 times more likely to report abnormal hearing quality. So really building this story that this is not just something that exists in the literature, but really might be a much larger issue that we should be paying attention to. So the prior studies that I just spoke about were really cross-sectional studies. If you look at a point in time, do you play sports? What's the hearing issues? Do you have a head injury? What's the hearing quality? Those are really a point in time. But what about if you track patients longitudinally? So to do this, I worked with colleagues who are again at the Brigham who work with the Nurses' Health Study. And so those that are not familiar with it, this is a group of nurses that have been followed since the 1970s and 80s, where you basically catch them at this point in time, and then you follow them prospectively with surveys to see what happens over the course of their lifetime might impact anything from cardiovascular disease to cancer to, for our purposes, hearing. And so what we wanted to do is see, did any of the surveys previously ask them about head trauma and the timing of head trauma? And there was a 2001 questionnaire that did look at this. And we also wanted to see, well, was this associated with another question that we asked along the way, which was self-reported hearing loss that was sort of moderate or worse in severity. So did they have hearing loss at some point in their life? And did they have a head injury. And what we were able to do is looking at these quite literally, this isn't a weighted average. We looked at 74,000 patients that were included in the study after similar inclusion and exclusion criteria. What we were able to find was that nearly 153,000 described a head injury at some point during life. And importantly, a lot of it occurred early on in life. And so what we found doing this sort of epidemiologic analysis was that a history of head trauma during very early on during life, in this case, it was 0 to 9 years old, was independently associated with moderate or worse hearing loss later in life. So clearly things that are going on early in life were had ramifications later on in their surveys related to their reported hearing outcomes. So again, that's just a little bit of epidemiology, looking at systematic reviews, looking at our own patient cohorts, and then looking at epidemiologic studies to say, this is probably a bigger issue than we maybe are realizing. Well, the next question clearly is like, what's going on? Like, why is this happening? So to do this, I again looked at the literature and said, well, are other people studying this? And the short answer is yes. There are a lot of, I would say, smaller reports that are going on, mostly in the pediatric literature and the concussion literature. They're looking at things like hearing loss, tinnitus, as well as hypercusis. A leader in the field is Dr. Nina Kraus out at Northwestern, and she's been doing various types of central auditory work to try to understand that following a concussion or head injury, do you have any changes in terms of central auditory processing? So I didn't want to look necessarily centrally initially. I wanted to say, you know, I'm a neurologist, otologist, what's going on at the periphery? So interestingly, I had a colleague, this was a medical student at the time, who had a friend that worked at a mixed martial arts gym. And so I wanted to know, you know, before and after their matches, were they having any auditory changes? And this was, you know, something that I worked, you know, somewhat hard to try to get done, because there are a lot of other types of sports where you couldn't necessarily capture head injuries right away. Football, they're wearing helmets and it's not easy to capture them, you know, right after a play. Other types of, you know, boxing is, you know, they might not have the same degree of head injury, or there might be in a boxing gym. But for mixed martial artists, they really do have head contact and they're being scored based on that head contact. And so what we did in this study is essentially do mobile pure tone audiometry before and after their matches. And these mixed martial arts fighters gave consent for me to take these pictures. And you could see in a quiet room, we did an FDA-approved audiometer. This is a shoebox device to be able to measure any potential changes. So we recruited 23 subjects. Their mean age was 26. And this wasn't people that are just showing up at the gym. A lot of them had been doing this for years. And so what was interesting about this study is that we were able to compare individuals who did and did not have head injuries. Again, there was scoring associated with head impacts. And so we were able to control essentially for if they did or did not have a head impact during their matches. And what you could see here is essentially the results. This is under review. On the y-axis, you have the mean hearing thresholds. And on the x-axis, you have pre and post sparring. So really pre and post sparring for the control ears, that's the panel A on the left, you don't really see much difference. But for the patients, or I should say the individuals that did have head impacts, you do see this very small but consistent threshold shift by about 5 dBs or so. And we did fork exams to try to figure out maybe there was fluid or this is a conductive hearing loss. It's hard to say exactly what is the cause of this shift, but needless to say, it was a pretty consistent finding. We're also able to plot it out based on the number of head impacts. So again, there was a scoring that was involved. And what you could see here is this clear trend, and it's more than a trend, that as the number of head impacts increases, you could see a worse and worse shift or change in your hearing loss. So again, I think there's a lot more work that needs to be done with this, but clearly after head injury, there is some sort of shift that occurs that might be similar to, you know, an acoustic overexposure. So the question is, well, what's the mechanism? So to do this, I feel very, very fortunate, similar to your group, that I work at an institution where I can study this using otopathology techniques. So I asked this very basic question: are there any pathologic changes that occur in the head and the inner ear following head injury? So to do this, I don't need to belabor this point, as everyone here is very familiar with otopathology techniques, but this had been done previously where we harvest the temporal bone. It's then processed over a year or two, and then we're able to study it. And so using similar criteria to the study that I did at the Spaulding Rehab Hospital, we looked at our temporal bone bank. We said, did any of these patients have a history of head injury during life? And we excluded those patients with noise injury, otologic surgery, or anything else that might bias the data. And we also excluded patients who had a severe postmortem changes, essentially due to too long a time period between harvesting and analysis. So what we found were 5 patients in our group that had a temporal bone fracture and 8 patients who had a head injury that was not directly associated with a temporal bone fracture. Notably for our study, the mean age of death was 65, and the mean time between head injury and death was 26 years. So this really isn't patients similar to the Shuknik feline model that they were studying them immediately thereafter or a couple weeks after. This is patients who were living many, many decades after their head injury. So this is a low power magnification view of an H&E stained slide of a normal individual. Everyone, I'm sure, who's listening to this is well familiar with this type of image. And what you can see here under higher power magnification is we're able to see the spiral ganglion cells and using techniques able to count them. This is an example of a patient who had a temporal bone fracture. You can clearly see the fracture line going through the inner ear. And you can also see evidence of new bone formation under the basal turn of the cochlea, as well as the fracture line going through the posterior semicircular canal. You don't need to be able to count to see that there's a paucity of spiral ganglion cells here, but we're able to count these as well. This is another individual who had a temporal bone fracture. You could see these microfractures along the cochlea. And again, even under lower power magnification, you can see her severe neuronal loss. And this is compared to an age-matched control. You could see degeneration of the organ of Corti. Again, you could see the fracture line really going up right near sort of the inner ear sensory neuroepithelium. And this is under higher power magnification, seeing essentially a denuded inner ear. But this was an interesting case, an individual who didn't have a temporal bone fracture, but had a history that was well documented of multiple head injuries during life. And you could see, and when I should say it occurred during life, it occurred during childhood. And you could see high drops of the saccule as well as the cochlea. Under higher power magnification, you could see atrophy of the stria vascularis, organ of Corti. You could see atrophy of the spiral ligament, as well as the missing tectorial membrane. This is I'd say, medium power view of the osseous spiral lamina, where you could see clear deficits in terms of the spiral ganglion cells. And we're able to count. And so what we did in this very simple bar chart is able to count, depict the spiral ganglion cells on the y-axis, and this is a percentage of normal. So in the light gray, you have controls, so 10 age-matched controls. And it's probably not surprising to anyone that after a temporal bone fracture, you could see a deficit in terms of spiral ganglion cells. But what was interesting in this finding is that even without a temporal bone fracture, if you had a history of head injury, you could see this clear deficit. So again, we don't know whether this is a primary or secondary loss of spiral ganglion cells, but clearly this is resulting or associated with a loss of spiral ganglion cells later in life. So this is maybe a little bit of a tongue-in-cheek image here in terms of what I think how otologists think about the central auditory system. I think about it almost like the wall for Game of Thrones. You know, oftentimes as neurotologists, we think about the tegmen and we think about the brain, and eventually, you know, sometimes we cross the wall to think about the central auditory pathway or sort of venture outwards. But for this question, I really wanted to study the central auditory pathway. I think a lot of the data about traumatic brain injury points that this might not be a peripheral issue, or it might be a combination of peripheral issue and a central auditory issue. So for that, I wanted to study the central auditory pathway. So for this, I do want to say this comes with a bit of a warning sign. This is preliminary data, and the topic that I'm going to speak about over the next few minutes is controversial, but I think we really, as neurotologists, should be thinking about it because it falls really within our purview of things that we should be studying. And so for what I'm going to speak about over the next few minutes is chronic traumatic encephalopathy. So for those that are not familiar with it, chronic traumatic encephalopathy is a bit of a controversial area in the field. This is CTE, what you might be reading about in the lay literature about athletes that later in life develop dementia-like symptoms. It was originally known as punch-drunk syndrome, later dementia pugilistica, and it was originally described by Dr. Harrison Martland, who was a medical examiner in New Jersey. And I have here a picture of his original paper back in 1928 in JAMA, where he described it. And this paper described things like tremors, slowed movements, speech problems, confusion, memory loss, psychiatric issues that a lot of these mostly boxers developed either during their career or later in life. But when one reads this paper and reads, subsequent paragraphs on the symptoms that these individuals developed, he very clearly writes that they also developed things like vertigo and deafness. So it was a little bit of an aha moment that maybe there is something going on, not just peripherally, but centrally as well. So CTE is sort of defined here. Again, for those that are not familiar with it, it's controversial, but what the thought is that it's this type of neurodegenerative disease that's associated with a tauopathy that occurs due to repetitive concussive trauma. And it's been associated with contact sports, falls, motor vehicle accidents, seizures, military combat. And the thought behind the mechanism, and this is evolving, is that when you have repetitive head injuries, you have a difference in, say, motion and a difference in the physics between what the brain parenchyma experiences and what the blood vessels within the brain experiences. So you have this sort of shearing force that occurs, and you develop these perivascular, blood vessel type of findings that occur. And there are different stages for CTE, 1 to 4, based on mostly the pathologic findings that you see. And so I wanted to ask a question, are there neuropathologic changes that occur along the central auditory pathway in patients with CTE? And the nice thing about this is that under normal circumstances, CTE is evaluated by looking at a whole series of nuclei within the brain. Similar to dementia, you want to look at 18 to 24 different areas, and 2 of them are the inferior colliculus and the primary auditory cortex. So what you might not also know is a lot of these brains are held about a taxi ride away from me at Mass Eye at BU, where we could study these brains. And so we looked at early stage, late stage CTE, as well as age-matched controls, and we wanted to exclude other types of degenerative processes. And this is a little bit of how we did the analysis. You could see the primary or auditory cortex as well as the inferior colliculus. You draw these regions of interest, and then what a computer is able to do is sort of plot out the plaque formation that occurs. So 12 controls, 12 early stage, 11 late stage CTE for both the auditory cortex. And there was a slight difference in terms of the numbers in the inferior colliculus because not every area is able to be retrieved. And this is sort of what it looks like under lower power magnification. Under the controls, you really can't see that many changes in terms of the staining, but under the late stage CTE, you can clearly see some staining of the plaque, the neurofibrillary tangles that occur. So that was the auditory cortex. This is the inferior colliculus, and you can clearly see evidence of tauopathy. We're able to measure this in a somewhat semi-quantitative way, where we measure the neurofibrillary tangles under a given area. And what you can see under late stage CTE is there's clearly deposition. So we looked at the auditory cortex. We also looked at the inferior colliculus. You can see a similar pattern here. And again, under higher power magnification, this is sort of what it looks like. And so the thing to take away with this is not that somehow the auditory cortex is being targeted, that CTE results in changes that are somewhat specific to the auditory pathway, but the auditory cortex is involved, and maybe part of the symptoms that patients have after head injury or repetitive head injury is due to this area being affected. I think further studies clearly need to better indicate whether maybe this is a area that is privileged, meaning it's protected, or maybe it's exposed. We don't know. We need to compare it to other areas that are implicated, but at least there's a proof of concept here that we do see evidence of this disease along certain aspects of the central auditory pathway. So that was a little bit in terms of postmortem studies, both in terms of the periphery as well as in terms of central auditory areas as well. So what about, if we're really going to study this, we really need to do this not just in postmortem human studies that clearly have some limitations in terms of the study. A lot of the times we're thinking about associations, like it's very challenged to say that head injury is directly causing the findings that you see on otopathology because there's a gap in time. It's very rare that you have a patient that you could do something right away. It's often, as the prior study showed, years later, and there are other things that could have occurred that maybe led to those degenerative changes. And so to do this, we wanted to see maybe that there was an animal model. So I turned to a colleague at the University of Pennsylvania, Dr. Douglas Smith, who works in the neurosurgery department and really a leader in large animal traumatic brain injury. And he uses a porcine model for TBI as it probably best replicates what's going on in the human condition in terms of TBI and the changes that occur. There are many types of changes. I should say there are many types of models that one can study TBI. One is sort of a concussive model where you essentially hit an animal on the side of the head. This model is a rotational model where you essentially rotate an animal very quickly to mimic the forces that you might see in a rotational injury for a human. So the first thing we did is take some of the porcine temporal bones and say, well, is this comparable? And so we did a study where we looked at porcine temporal bones and we compared it to human temporal bones, and what you can see here on the left side of the screen is the human temporal bone, on the right side of the screen is the porcine model. And for all intents and purposes, it seemed like a relatively reasonable model, unlike a mouse model that has sort of a bulla and other rodent models that has a very airfield bulla. The porcine model seemed somewhat analogous to the inner ear in terms of its layout, and that it wasn't just sort of this wide open airfield space. And so what we're able to similarly do to our human cadaveric studies is harvest them, and we use the same instrumentation as we use for our cadaveric studies. It's actually somewhat nice in a porcine model. This is sort of like a bird's eye view looking down at the skull base. You could see the porous of the internal auditory canal quite nicely. So it allows you to really target your dissection with the cadaveric saw. And so this is a low power magnification view of an H&E stained slide of a porcine inner ear. They clearly had many more turns of the cochlea as the human does, but we're able to sort of examine it in a way that is somewhat similar, analogous to the human condition. And again, I'll just put the caveat out there that this is preliminary data. And so we're able to see here that what this model showed was the animal sustained a head injury, a rotational injury, that they were then able to live with this head injury for 2 weeks, and then they were sacked and examined. So here you can clearly see changes that occur the inner ear and the organ of chordae. There's this sort of bowing out that occurs. There's also this sort of precipitate that we're sort of trying to understand in the scale of media what this might be. Under higher power magnification, you can clearly see this degeneration of the inner ear and outer hair cells. Interestingly, for those that are interested in the vestibular system, and while it's not the focus of the talk, we also see collapse of the superior semicircular canal. We can see this hydropic type of appearance that, to my knowledge, it really hasn't been shown previously. What was also interesting is we saw otoconial detachment from the saccule. A lot of patients, and this has been well described in the human literature, that after head injury, they're more likely to experience BPPV. And this might be sort of a snapshot of why this occurs. So this study clearly needs a little bit more rigor in terms of understanding what functional changes. It's a little bit challenging to do auditory brain responses in the porcine model. And so we really need to sort of understand, do these changes that we're seeing pathologically have actual functional changes? And so just a glimpse in terms of what I'm doing in the future is really adapt this for a mouse model, which is a much more robust model to study the auditory pathway, both centrally as well as peripherally. So that's a little bit in terms of what I'm thinking about in terms of animal studies, but I think everyone on the call and the meeting is wondering, well, what can I do for my patients? Somebody comes in, what can we do? The short answer is we just don't know. There are some studies in the literature that talk about steroids, after head injury, but this is sort of fraught with issues. There's oftentimes other comorbid things that occur with head injury, especially traumatic brain injury, where high-dose steroids might not be a good idea. Similarly, it's not always feasible to do an intratympanic steroid injection after a head injury, and especially if there's no great data to suggest that it works. Again, it's hard to say that you should definitively do this. So I think from a very practical standpoint, we're not quite sure what the best treatment is in terms of any oral or IT steroids, and this is something that really does need a lot more research to try to understand it. My thought is if we understand the mechanism, then we might be able to better target treatments. And if we develop a model, an animal model, we can surely look at whether steroids provides some degree of rescue for any potential hearing loss. The second question is surgery. And so clearly surgery is implicated. And if there's any sort of conductive hearing loss and after they might have developed fluid or a hemotympanum in the case of a more severe TBI or temporal bone fracture, clearly surgery is indicated. But what about after a sensorineural hearing loss? What about weeks or months after their head injury? They have a sensorineural hearing loss and there may or may not be evidence of a temporal bone fracture. So we wanted to study this a little bit. And again, I was fortunate to work at Mass Eye and Ear where we can examine it. So in this paper that we published a few years ago, we examined 2 patients with a history of head trauma that resulted in a bilateral temporal bone fracture. They then also had a sudden and profound sensorineural hearing loss. Both cases underwent subsequent unilateral cochlear implantation. And so what we really wanted to do in this study is understand, well, what's going on? We can sort of compare the CI side to the non-CI side. You sort of have an inbuilt control. And so we wanted to understand things like the fracture line, any fiber osseous changes, as well as look at spiral ganglion counts. This is a low power magnification view similar to those that I showed previously, but here you can see with the sort of red star on one side is the track of where the electrode went. And so what we found both, in both these cases, and this is just the second case showing the same thing, the fracture line, as well as the cochlear implantation site, is that the implanted side showed extensive intercochlear ossification, which was greater than the non-implanted side. And it's really impossible to know whether this was there before or after implantation, but maybe that this after a temporal bone fracture, these ears are more fragile, that if you introduce a cochlear implant, that you might see more or an exuberant deposition of fibrosis or ossification that is different than the side that doesn't have that additional trauma from a cochlear implant. So the intraoral spiral ganglion counts were also lower on the implanted side than on the contralateral side. And so again, it's hard to know because you can't examine these patients before implantation, but maybe this speaks to a certain degree about some of the changes that might occur or the expected changes that might occur after implantation and the expected audiometric outcomes. But even though that there were these intraosseous fibrous depositions and ossification, I wouldn't say that this is bad news whatsoever. We also did a study where we looked at just clinical outcomes after head injury, those with and without temporal bone fractures, and many in the audience might have done cochlear implantation after temporal bone fracture, after head injury. And I think the general consensus, if you look at the literature, is that patients actually do quite well, after a CI. Some do better than most, like all sorts of heterogeneity with cochlear implantation, but there are many, many patients that do well. But what we wanted to do specifically in this study is look at patients who were indicated for a cochlear implant, those with a temporal bone fracture, but those had head injury and without a temporal bone fracture, so group A and B. And so we examined 24 cochlear implants after head injury. 20 of them resulted in a full electrode insertion. You can imagine, based on what I just showed in the previous slides, some might not be able to have a full insertion because of inner ear changes, but the vast majority were able to have full electrode insertions. Notably, what we found is that over 70%, 79% had a CNC score greater than 50%. So these individuals do quite well after cochlear implantation. And what was also important is that there was really no difference, at least statistically, in terms of those that had a temporal bone fracture in group A compared to those that had a severe to profound sensorineural hearing loss after head injury, but did not have a temporal bone fracture. So the major takeaway from this study is overall, cochlear implantation appears to be a viable option for auditory rehabilitation in patients with severe to profound hearing loss. So again, I don't want the otopathology to scare anyone away. Patients do quite well, even in the absence of a temporal bone fracture. So that's sort of where we are, I think, in terms of clinical therapeutics. Surgery, steroids is a big unknown. CI is generally indicated. Clearly, we could do middle ear surgery if there's a conductive hearing loss. Regenerative therapies, I think, are on the horizon. I think as we know what the mechanism is, maybe there will be a targeted regenerative therapy. I think it's an exciting time to be a neurotologist, just because of all the things that are in clinical trials, and maybe similar to those that have an age-related hearing loss or a specific type of genetic type of hearing loss, maybe after a temporal bone fracture or a head injury, they would be candidates for this type of regenerative therapy. So that's sort of just finishing up how I'm thinking about putting these pieces together. I would put a charge out there and say, as neurotologists and otologists in general, we should be up to date on the literature in terms of head injury, and traumatic brain injury is really where it's at in the nomenclature for those individuals who sustain head impacts. And I think we should be thinking about, what is our nomenclature? How do we describe this phenomenon? I showed earlier on the talk that sort of laundry list of possible mechanisms that we describe as an inner ear concussion or a labyrinthine concussion, but really it's much more nuanced than that. I think that we really should begin to think about this as a traumatic auditory injury that has different mechanisms, whether it's peripheral or central, and we really need to sort of come up with further characterization about what this might be. And so that's sort of what I am thinking about now, how I'm sort of putting together the puzzle, and those are my sort of general thoughts. So just to finish up, this is the major takeaways from the talk. First, auditory dysfunction after head injury is a potentially under-recognized phenomenon and may present with or without threshold shifts. I hope that study out of Spalding Rehab shows that the patients that experience at least subjective hearing loss, hyperacusis, tinnitus, oral fullness, that's real, and they probably do have changes that are occurring at the cellular level despite our crude audiometry that is not showing it. We need to tell patients that, yes, I believe you, what you have ongoing is real. We just don't have sensitive enough assays to detect it. The next bullet point sort of ties along with that. There are clear otopathologic findings that occur, and there are reasonable CI outcomes. I think this is something that we could potentially offer patients now, especially as hopefully more regenerative or inner ear therapeutics, come online. I just want to thank, my research team, in particular, Dr. Renata Knoll, who is currently a PGY2 resident at Mass Eye and Ear. She did a lot of the work that I presented today when she was a research resident in my lab. And I've also been actually very fortunate to collaborate with individuals at House for other studies related to cochlear implantation as it relates to temporal bone imaging and studies. So, thank you for, collaborating as well.